Hello, everyone. Welcome to Doctors ACO Digital Lunch and Learn today on this lovely Wednesday. We appreciate you all logging in and joining us. I've got everybody on mute right now just to make sure that we don't have any background noise. But I do want to remind everyone that you can use the chat function to ask questions. We're also asking everyone to use the chat as a way of taking attendance. So if you wouldn't mind, go to that chat button and type in your name just so we know that you are here and attending our Lunch and Learn today. Those of you that have a webcam, hi. We appreciate you all joining. We're going to go through this as quickly as possible. I hope everyone has their sandwich or their lunch today and are ready to learn a little bit about home health. This is going to be a bit of a review for some of you. Anyone that's joining us from Ohio will recognize this presentation, but it's a good review. We want everyone to be comfortable reading their home health orders, feeling comfortable marking out things that they don't think their patients need, and just having a good idea of what their patients are getting. So I'm going to go ahead and switch my screen over, turn off that webcam. All right, and here we go. So this presentation was initially put together by Ginny Williams, who is a nurse that works with a few ACOs down in Florida. She has extensive background in home health, being a home health nurse, and she knows how to read these orders front and back. So she's put together a presentation for us. She actually came up and did a presentation at one of our members' meetings not too long ago. But I'm going to go through her presentation here and hopefully do her justice. So just a few things to refresh, and we're going to go over a lot of these. Remember that home health care is a physician-directed service. This is not to be directed by the home health nurse, the home health agency. It is directed by the physician of the patient. Home health care can't be billed without the signature of the physician. And it is really designed to help prevent rehospitalizations. Most of the time the patient has had a hospitalization first. We want to keep them from being readmitted. Home health is most often paid for 60-day certifications. There are a few exceptions to that, but pretty much you're going to do 60-day certifications of home health care. You'd have to do a recertification at the end of that 60 days. And again, the physician has to sign off on both of these. A reminder that home health care is only a covered benefit for skilled services. Assistance with ADLs like bathing and cooking and things like that are not considered skilled services. And so that's not something that that Medicare will cover home health care for. Patients do have to be homebound to receive services, and this does not mean bedbound, just homebound, and we'll go over a little bit more about that. And then you have to have a face-to-face encounter with the patient, either 90 days prior to the start of home health care or within 30 days after the start of care. Medicare wants to be sure that the patient is seeing a physician and the physician is aware that they're getting home health care and that that they're having some issues. So we're going to have some resources for you up on our website. On the Doctors ACO website, you'll find this homebound requirement checklist to help you out, a few other things on our website. So if you haven't visited our new website, go on over there, sign up to be able to log into the resource library. It's really easy to access, and you'll be able to find this presentation and any of the things that we go over today. So this is just an example of a homebound requirement checklist that you can use when you're trying to decide if a patient really is homebound. Patients can't opt to be homebound. They can't say, well, I really need home health, so I'm going to tell you that I'm homebound. They really need to be medically, it's got to be medically needed. So being homebound means that it is taxing to leave the house. Not that they can't leave the house, but it is taxing. This gives you a little bit more information about it. They don't have to be bedbound, but if they require a walker or wheelchair to leave the house, they need special transportation. They need someone else to help them get out of the house. If leaving the home is medically contraindicated, or if certain symptoms get worse when they leave the house, if confusion gets much worse, if they get very short of breath, if pain gets a lot worse when they do leave the house, all of those would help consider a patient homebound. So if they do leave the house every once in a while, infrequently and for short durations, for example, going to church, going down to the barber shop, going for a walk, things like that, that doesn't disqualify them from being homebound. They can do small trips like that, infrequent trips, and still be considered homebound. Just to let you know, some of you may not be aware that home health reimbursement to the home health companies is based on clinical severity of the patient, their diagnosis, and functional status, and how many services that they're using. Do they need physical therapy and occupational therapy and speech therapy? So this is why we want to take a critical look at our home health orders. Of course, most home health companies are great and they're going to follow the rules, but there will be some that are going to try and throw in some extra services because that's how they get paid. So we need to look over this stuff critically. And for continuous home health care for a patient that gets it all year long, it can be upwards of $42,000. If they need it, great. But if they're getting extra services that they don't need, this is a big chance for savings. So just a few things. We want to make sure that you have the original order for home health care before you sign off. We don't want to ever see scripts for home care eval and treatment. This means that the home health company gets to evaluate the treatment plan for the patient. That's really up to the doctor. So you don't want to give them that power, essentially. They need to, within 14 days of the start of home health care, they need to get that plan of care to you. It is unacceptable for a home health care company to wait 30, 45 days before sending you that plan of care for your signature. We've seen it happen before, and you can refuse to sign. They'll come back to you and say, but we won't get paid. Well, that was your own fault. Completing TCM visits is a great time to really assess that patient and see if they are homebound and if they really do need these home health care services. All of this stuff ties in together. So doing TCM visits on your patients is a great way to make sure that you're seeing them quickly and making correct decisions on home health care. And of course, you always want to see the patient again prior to recertification. At the end of that 60-day period, it's a really good idea to see your patient again and make sure that they do need continuing care. Home health care does have to have attainable goals. You have to see some medical improvement. Custodial care, we don't want to just have custodial care for your patients, and you don't want to be signing for non-covered benefits. Like we mentioned earlier, the ADLs, cooking, cleaning, helping, walk around the house, changing Band-Aids, many things that aren't covered. You want to be able to see your patient getting better. Home health care has to be limited in scope, and your patient has to show improvement to qualify for home health care. So these are just a few notes on editing this plan of care. Remember, you are the physician and you are in charge of the plan of care. We never want to sign orders that include automatic recertifications. You need to be in charge of when that patient gets a recertification and if they need it. Automatic resumption of care post-inpatient stay. So this essentially says that if your patient goes back into the hospital The home health company can just continue on where they left off if you, once they get out of the hospital again. You don't ever want to see that in your home health plan of care. You need to see that patient again after they get out of the hospital and decide if home health care is still appropriate and if all the things that were signed for initially were still appropriate. You'll see every once in a while, they will put in a line that says, any provider participating in the patient's care may alter these orders, something along those lines. So that means the patient's podiatrist can decide if they need home health care, skilled nursing in the home. If you see that, feel free to cross that out. That's not appropriate. You, as the primary care doctor, need to be the only one that signs off on these orders. Of course, check to make sure that all the diagnoses are correct, and read the plan of care and cross off items. We're really looking to open dialogue with the home health companies, not create confrontations. And for some of you that have already started doing this, you know that they'll come back to you, and sometimes a little forcefully, and say, no, you have to sign these orders. Open up this dialogue. We want to talk to them and let them know why we're crossing things off, and why we are trying to improve the care of our patients. So these are a couple of things that we don't need home health care for. Simple dressing changes, wound care that can be completed in the office. If they can come into your office, you really need to see them for that wound care if at all possible. Remember, ADLs are not a covered skill. Maintenance therapy, meaning we're just going to hold the patient right where they are. They're not going to get any better. They're not going to get any worse. That's not a covered skill for home health care. Home health is to help a patient improve. Lab draws should not be something that they do in the home. Jessica, take a point. And remember that you do get paid to do this. These are the two codes that you can bill for going over your home health orders. The GO180 is for the initial certification. Patient doesn't have to be there. This is just you reading over the orders, crossing out stuff that is not appropriate. And then the GO179 is for the recertification. It pays just a little bit less because they assume that you've seen all this before. You can go through this a little quicker. Be careful when you're billing these codes. Make sure that you have good documentation that you have had a face-to-face with that patient, either in the past 90 days or within 30 days of the start of home health care. And keep a copy of that plan of care in their chart. You can earn quite a bit for doing, looking over these home health orders. And especially if you put this together with a TCM visit, you can see that managing your patients right out of the hospital can really be a lucrative thing in your practice. So the OIG is really trying to crack down on fraud within home health care agencies. This just is a little blurb saying that they've reached criminal convictions and civil settlements with home health agencies, individual physicians, and heads of companies. So they have come after individual physicians who are just kind of robo-signing those plans of care or extending home health care for a patient that doesn't necessarily need it. I hear a lot from practices, from providers, that I just don't have time to review that whole long home health care order. You don't have to go through the whole OASIS form, the big long 18-pager or multiple pages. Really, the only thing that you need to look at is the order, which should be about 1 page, and the plan of care, which is a few pages, and that shows the different skilled services that they're getting, the PT and OT, and how often they're getting it. I see we've got a question in the chat here. I'm going to pause real quick. Our question says, why not confront them when you did not order the home health care orders? So, that's great. You can definitely confront these companies if you didn't order and they're sending them to you to sign. If you don't think that's appropriate, let them know. You are not required to sign these orders if it's not something that your patient needs. However, the hospitals really are taking the lead on this and are going ahead and signing your patients up for home health. You have to pick your battles sometimes. If it is something appropriate for the patient, sign it off, sign off on it. If it's not appropriate though, cross off things that you don't want done that are not needed by the patient. And again, you don't have to sign if you did not order. We want what's best for the patient at all times, of course. Okay, the plan of care. This is all going to be shown in the examples, so I'm going to kind of skip through this. These are some case-by-case reviews. This is really the meat that I want to show you guys. So some examples of what to look at in your home health orders. So first thing you want to look at is that start of care date. So this is when your home health, the home health certification started initially. And then you've got the certification period right next to it. So remember, each certification period is 60 days. So that date will update every 60 days for the certification period. You can see that on this order, it's more than a year and a half after the initial start of care date. This is episode number 10 of home health for this patient. So this patient's either really, really sick, or maybe getting things that they don't need, or not getting enough of what they need. So check out the diagnosis. The principal diagnosis should be the reason why they are getting home health care. And then there'll be other pertinent diagnoses. This does not mean every single thing that the patient ever had is written on here. These should only be things that back up the need for home health care and show really how sick the patient is and what they need. So don't be afraid to cross off some diagnosis if you think that they're just trying to milk this a little bit. If it's something that does not matter to what is going on with the patient right now for this home health care, you can cross off these diagnoses. So this is still that same order. This shows how to look at the number of services they're getting and what they're getting. So the top circle there that says SN for skilled nursing, 1 week 9, means that the patient is going to receive 1 visit per week for 9 weeks. Now remember that this patient is on their 10th certification, and they're only getting 1 nursing visit a week. Do we think that's enough? It very well might not be if they're getting certified over and over and over again. Once a week is probably not enough. Maybe this patient needs a shorter duration of time, but more often during the week. The second red box there, read that line. All physicians involved on this patient care may write orders. Again, this is saying that even the patient's podiatrist or the patient's OBGYN, whoever, can write orders, can add these home health orders. You are the primary care doctor. You really need to be in charge of this, not someone that they only see maybe once a year or less. Still the same order here. You go down to the bottom. This is the last page of that 3-page order. And it says that the patient is not expected to be discharged this episode. They will continue to need ongoing skilled care. So again, we have to ask, what is going on with this patient that they're not expected to be better by the end of the 60-day period? They've been doing this for over a year and a half, and they're only getting 1 skilled nursing a week. This doesn't seem to add up. These are things that we want to try and catch. Maybe this patient needs to be coming into your office a little bit more often, or again, needs skilled care more often during the week, more than just once a week. And just a review, again, 10th episode, it seems like nursing is inadequate to reach these patients' goals. And the doctor knew this patient and knew that they ambulate with a walker and with minimal assistance, so that they probably weren't even considered homebound, at least not anymore at this time, a year and a half after the start of home health care. They are no longer homebound. So by canceling this home health order or even cutting it down, we're saving a lot of money for the ACO and potentially getting the patient better care in a better place. They can be coming into the office to get this care, and maybe even will improve better if they can come to see you a little bit more often. All right, so this is a second example here. Again, we want to look at the start of care date and the certification period. This is the first certification period, and they just started the care. And then the diagnosis, we want to look at the principal diagnosis, is the reason why they're getting home health care, and then other pertinent diagnoses that would back up the need for that care. So looking at our modality of care here, skilled nursing, 1 time a week for 1 week, and then 1 time a week for, let's see, multiple weeks, 1 for 3 weeks, and then 1 nursing visit every other week for 6 weeks is what this is saying. So a total of 6 nursing visits. This doctor decided that that was not appropriate. They didn't want someone to come every other week. They wanted a little bit more, so they did not sign off on this order. They told the home health company no. The home health company then proceeded to fax this back to them over and over and over with no changes, and would not accept what the physician wanted. They can be tough. So hold your ground. Remember that you know your patients the best. Cross out what you don't need. You see that this physician wrote skilled nursing 1 time a week for 4 weeks only, rather than the multiple weeks and every other week. So write what you want. Don't be afraid to pick up the phone and call, or have your nurse call the home health company and ask for more clarification, or to let them know really what you want and how you need to write it on there. You don't have to use their language, this 1 week for, you can write on there 1 time per week for 4 weeks only, or, you know, skilled nursing only, no physical therapy, something along those lines. Write whatever you want on these orders, whatever is appropriate for your patient. And again, this was Ginny's chart review. I've got, looking at our chat here, let's take a quick pause. One of our listeners today says that developing a relationship with the home health company helps. Telling them that you want a phone call to start out or for any significant changes or research, but you have to take the time to talk with them when they call. And really, we've had a lot of physicians in our ACO that have developed relationships with their home health care companies that they use frequently, and they will reach out to them and ask opinions. They will respect the changes that they make to the home health care orders. We really encourage you guys to talk with at least your most used home health company. I'll show you in a minute how to look at maybe which companies are most appropriate in your area based on costs and research rates and star ratings. But developing relationships is important. You know, we're all trying to help the patients get better. We want to make sure that they're getting the appropriate care and that all of their providers are working together for this. So going back to our example here, this order was not originally given by the PCP. It was given out of the hospital. It was for wound care, which was really ended up just being a skin tear. And the patient was mobile. They were able to go to the doctor's office for weekly visits. So they did not even, home health care was not even something that they qualified for, since they were not a homebound patient. So these costs really do add up for things that are not necessary. Remember, skilled nursing, it's got to be a skill. for them to qualify for this. Band-Aid changes for a skin tear is not skilled, not considered as skilled nursing. So just a few reminders here. Set the expectation with your home health company that a face-to-face must be within 1 week. So let them know that you want to see this patient, or you're not going to sign orders on them. Maybe they can, since a lot of this originates in the hospital, this may be a way to for us to know that our patients are there in the hospital. If the home health company understands that you need to see that patient quickly out of the hospital, they may contact you rather than the hospital contacting you when a patient is there. Don't forget to bill when you do review these orders. An extra $50 is not a bad thing. And you're taking a few minutes out of your day to do it, make sure you're getting reimbursed for it. Cancel these orders if the patient is not homebound. Remember that your signature is the one on these orders, and you are the person that CMS is going to come back to if they suspect that the patient does not qualify for this service. If you signed off saying that, yes, this patient is homebound, and yes, all of these diagnoses are correct, and yes, they need all of these services, when the patient really doesn't, CMS and the OIG can potentially crack down on you. So, your reputation is on the line here. Make sure that you are reading these when you sign them. Okay, and I wanted to show you guys quickly that you can see your home health data in Blue Sky. I think pretty much everyone has logged into Blue Sky at this point. If you haven't or don't have a login, if you need some more training on it, please get up with me or Travis or Neil. We'll help you get through Blue Sky and show you where to find all this stuff. But if you go to the ACO Insights menu on the left side, click on that, you'll find about halfway down the page HHA for home health agencies. This is looking at all of the patients getting home health care in the ACO right now. But you'll see that 687 is the number of home health, of patients getting home health right now in the ACO. If you click on that number, then you'll get to see all those patients in your practice that are getting home health. You can see who ordered the home health. You can see the agency that they're getting it at. I sorted this list by length of stay so that I can see which of the patients have been in home health the longest. You can see that this top one has been in for 147 days. So that's in their third certification period. We want to make sure that it is something that they still need 147 days later. And really that's going to go out to, 60 times 3, 180 days, because they are 60-day certification periods. So you can see this for your practice, all the patients that are in, and you can click on the patient to get a little bit more information about it. You can also filter your home health admissions by facility. Up there in the top left corner, there's a filter view. When you look at this by facility, it gives you the star rating of the home health care agency, and that comes from CMS. You can look at the total number of admissions within that agency. You can look at the cost per admission or the cost per day. Oops, let's go back. And I would also look at the recertification rate. So some of these agencies that have very high recertification rates may be a little suspect. If most of their patients aren't getting better with the first couple of certifications, you continuously have to recertify these patients. That might be a red flag for you. So for anyone that is already doing this, we'd love to hear from you. We would love to get a little bit more, get to know your experiences. Let's see. Hold on. Bear with me. I'm looking at our chat here. All right, so we've got a question. How do we keep the hospital home health agencies out of the loop if our patients are seeing an outside agency as they're being discharged from the hospital. So, you know, this is a good question. Most of, at least our hospitals here in Athens, have their own home health care companies, and they automatically send the patients to their home health care companies, potentially rather than the one that you would like them to go to. So really the only way to do this is to catch your patients early, catch them for their TCM appointments. Have to catch them right out of the hospital. I know this is a tough thing. We're all working on trying to figure out when our patients are in the hospital and get the hospital to talk with us. But that's the best that we can do, is to catch them early, directly out of the hospital. And then we can either cancel the home health care that they are getting from the hospital-based one if needed, and sign them up for the one that you prefer, or just letting your patients know at the TCM visit that, you know, let them know to call your practice if they have questions about home health care, about skilled nursing, things like that. Share the information that you know with your patients. You can even put up signs in your waiting area or in your offices about your preferred home health care company, if, you know, for patients that might need this. But this is a tough thing. We don't have all the answers on how to keep them out of the hospital and how to keep them out of the hospital-based home health care if that's not the most appropriate one for them to be in. So check out your blue sky. I'm going to go back here. You know, look at the facilities that your patients are going to. Look at their star ratings. Look at their recertification rates. Choose the companies that you think are best caring for your patients. And that might not be the one that has the, you know, the lowest cost per patient or cost per day, but we want someone with, you know, with a good star rating and with low recertification rates. So I would love everyone to go and look at their own data. When your provider consultants come out, they would be happy to go through this stuff with you as well. All right, do we have any other questions? Anyone have anything else to put in the chat? Or does anyone want to share some experiences? I'm gonna unmute.
Unmuted.
Would anyone like to chime in and let us know how things go in your practice? All right, well, a reminder that on our website we do have that homebound checklist and a few other things. We have the face-to-face documentation for when you do see the patient and evaluate them for home health care. And we will be sharing this slideshow and this recorded session on our website as well. So if you haven't been to our new revamped website, thanks to Travis, head on over there, sign up so you can get into the resource library, and we'll continue to put new things up there for everyone. All right, and I think at this point, we've gone through everything that we wanted. We tried to keep this short and sweet for you guys. I hope you liked this format. We're going to try and do some more lunch and learns like this on topics that we think are pertinent. If you have a topic that you would like to hear to do a lunch and learn on or to hear discussed, let us know. We'd love to hear from you all. Okay, we're going to end this. Thank you all. Have a great rest of the afternoon.